I will take it over. All right. Well, thank you everyone for being here with us today for our second mental health parity webinar event. My name is Audrey Dunkel, and I am the chairman of the Parity Committee. These events are intended to provide you with perspectives relating to how behavioral health coverage is provided under insurance parity rules, regulated at both the state and federal level. Ooh, more caffeine today. Our goal is to give you current information and engage with representatives of providers, stakeholders, policymakers, and the insurance industry to help us all learn from each other, because we know this is how policy is made, how these discussions move forward, is all of us talking to each other. Now, the Mental Health Coalition is a roundtable of nonprofit organizations, agencies, and individuals representing consumers, families, and providers that's dedicated to improving the lives of Kansans who live with mental illness. The Parity Committee then was convened because parity and equal insurance coverage for behavioral health is federal and state law, but policyholders often have difficulty getting insurance approval for treatment and necessary medications. And we truly do believe that there is improvement necessary to keep us moving forward. Now, on to the main event, of course. I'm pleased to introduce David Lloyd, who is the Senior Policy Advisor at the Kennedy Forum, who is our special guest today. And he's going to talk about the work of the Kennedy Forum regarding mental health parity. Now, interesting thing about David, he has started rock climbing, which I think is terrific and a little bit scary because I don't do heights, but I do appreciate reaching out and doing something a little bit different. David, you don't look like you have too many bumps and bruises, so that's good. Good to know, good to know. So a little bit about the Kennedy Forum before I hand it over to David. The Kennedy Forum seeks to transform the way mental health and substance use disorders are treated in our healthcare system by advancing parity, quality and transparency, integration, technology, brain health and fitness, and youth mental health. Now, as David gets started, I know you all are going to have questions. So if you would please put those questions in the Q&A, not in the chat, in the Q&A, so that we can keep track of those. We will keep a list of those. And once David has completed his discussion, then we'll work our way through those questions. David, I'm going to turn it over to you.
Well, thank you so much, Audrey and Amy and everyone for joining us today on what I think is a really important topic of mental health and addiction insurance coverage and mental health parity. So hopefully, I can provide some background. I'm happy to answer any questions you have as we go along. But hopefully it will be a robust discussion on really how we pay for mental health and addiction coverage, because if we don't pay for mental health and addiction coverage, it will be underprovided. And I think for a long time, what we've seen is that historically, at least for decades, mental health and addiction services have not been covered by health insurance in the United States. And that really meant that services weren't available when people needed them. And so over the last couple of decades, there's been a movement on a bipartisan basis to change that, to make sure that people can get the mental health and addiction services they need. And it's important for people to be able to afford those services, for there to be health insurance coverage. If your health insurance that you have isn't reimbursing for services that you need, it's often very difficult for patients and their families to get those services, because they simply can't afford to pay the out-of-pocket expenses. So I'll give, first of all, a bit of overview of the Mental Health Parity and Addiction Equity Act, which is a landmark federal law in this space. That was passed in 2008, and our founder, former Congressman Patrick Kennedy, was lead co-author of the Mental Health Parity and Addiction Equity Act. I'll sometimes say MAPIA, which is the acronym for the Federal Parity Act. And so that has been one reason why we've had this as a major priority of making sure that the law is implemented appropriately, so that the rights that it provides are actually realized by everyday Americans who need access to these services. So essentially, the Mental Health Parity and Addiction Equity Act was was passed on a bipartisan basis in 2008 and signed into law by President George W. Bush. And what the law essentially says is that in health coverage, insurers cannot discriminate against mental health and addiction coverage as compared to physical health coverage. And so the law sets up a number of different kind of tests to kind of make this kind of operationalize that general framework. And kind of the first bucket of the Federal Parity Act has to do with what are called financial requirements. So these are the things you have to pay out of pocket for. Your responsibility, as an enrollee in a health plan when you are receiving services. You often have a copay and you have a deductible. Those are your financial responsibilities that you have to pay in order to receive that care. So the Federal Parity Act essentially says that higher co-payments and other out-of-pocket expenses for behavioral health can't be higher than they are for physical health. So you can't have $100 co-payment for a mental health therapy visit, but only a $20 copay to see a medical specialist. So broadly speaking, these types of out-of-pocket expenses have to be the same, or else they run afoul of the Federal Parity Act. The second bucket of the Federal Parity Act has to do with really day and visit limits on mental health and addiction services. So oftentimes, there will be limits in health plans that will say, for certain services, you may be, and I'm making this number up, but you may be limited to 30 visits a year, to a mental health therapist or something like that. And again, broadly speaking, any limitation like that, has to be, can't be more stringent on the behavioral health side as compared to the physical health side. So again, it's always this comparison between mental health and physical health. And then the third, and this is probably the most important bucket of the Federal Parity Act, has to do with all the other limitations on treatment, which the term of art under the Federal Parity Act is a non-quantitative treatment limitation. So these are any limitations that are not numeric in nature, so it's not a 30-day visit limit, but it's things like prior authorization requirements, step therapy requirements, network admission standards for providers that are non-quantitative in nature, but yet have an effect on the treatment that you receive and can limit the amount of treatment that is covered by the health plan. So this is the third bucket. And again, in general, each non-quantitative treatment limitation, so let's take prior authorization as an example, has to be comparable to the same treatment limitation on the physical health side, and it can't be any more stringently applied. So if you had prior authorization requirements on all mental health medications, and you didn't have prior authorization requirements on all physical health medications, that would be certainly, well, I would think that would be a straight out parity violation, but it would definitely would signal that there's something likely amiss in violation of the Federal Parity Act. So fundamentally, it's an anti-discrimination law at the federal level that requires this comparison between behavioral health and physical health, and it really can be a very powerful tool to ending what historically has been discriminatory coverage for behavioral health. And so in the areas where there tend to be kind of quantitative, where there are, where things are quantitative in nature, like with the, what you pay out of pocket, dollars and cents, and kind of number of days or visits that you might be limited to. These have kind of discriminatory practices have by and large gone away. So we've seen a lot of progress, and that's in part because of the nature of kind of the limitations are somewhat obvious on their face. Like what your, they're in plan documents, You can, if you see, like, if advocates or your patients see discrimination, it's often, kind of black and white on paper. So for the most part, we made a lot of progress in those areas. The problems we continue to see are more with the non-quantitative treatment limitations, like prior authorization and other types of practices, treatment exclusions that are inherently a little bit more, ambiguous in nature. They aren't necessarily always written down in the plan documents themselves, and so it takes a little bit more digging, to see what these treatment limitations are and whether or not they're compliant with the federal Parity Act. So I should say here, just as because this often comes up, there are different types of health plans, and this is actually a very complicated space of, like, if you are having problems with insurance coverage, and if you think that there might be potential parity issues under the Federal Parity Act, you really have to go to the right regulator. And that can differ significantly based on the type of plan that you have. So in general, fully insured plans, which are the plans where you're purchasing, or your employer is purchasing an insurance, health insurance from a firm like Aetna or United, those are regulated by your state insurance department. Whereas if you are perhaps employed by a large organization that is what's called self-funding their plan, the state won't regulate those health plans, because they're different in nature, and they're only regulated by the federal government. To make this even more complicated, for Medicaid, which is subject to the Federal Parity Act in most instances, including wherever managed care comes into the equation, the enrollee is protected by the Federal Parity Act. The Medicaid agency in each state is responsible for oversight. So it becomes quite complicated in terms of who you go to help. You need for help if you think that there's an issue. And the what we've been working on nationwide with both states and the federal government, though, is really to take the burden off of consumers and patients individually, because that really sets patients and their families up for a lot of problems. But over the last, I would say, for the majority of the time since the passage of the Federal Parity Act in 2008, we have put the responsibility too much on individual patients. So we've expected in most states, the insurance regulator and the Medicaid department has essentially, and this is changing, has essentially sat back in many instances and waited for complaints to come in. And most enrollees, though, and their families are not well positioned to one, understand all the nuances and details of the Federal Parity Act and the requirements, and even more fundamentally, even if they do understand the requirements of the Federal Parity Act, they're having problems with mental health or addiction coverage, so they don't see what is happening on the physical health side, because they don't necessarily, they're not seeing how that treatment limitation that they're being subject to is happening on the physical health side. So they simply don't know if there's a parity problem. And so to expect the consumer who is often going through a mental health or addiction crisis and their family to figure all this out, while they're may well be in crisis, is really a hill much too high to expect them to climb. So we have been pushing with partners both at the state and federal level to really make sure that the oversight is done by the relevant regulator, to make sure that the regulator is looking at health plans compliance and making sure that the treatment limitations that they're applying are compliant with the Federal Parity Act, so that the burden isn't on individuals and families who are going through, again, often experiencing a crisis. So there are many initiatives that have been pushing this forward. one of which is the National Association of Insurance Commissioners for commercial plans. It's called NAIC. They actually have a MAPIA working group in which I think there are 30 states are now participating, and this has increased dramatically over the last couple of years. Kansas is participating in this, so that is really good news that that your insurance department is participating in this working group, which is really collaboration among states to learn from one another on mental health parity and how to better oversee health plans. There's also been a dramatic increase in activity among federal agencies in the last couple of years. They were at the end of 2020, President Trump signed into law legislation that requires most commercial health plans to conduct detailed parity compliance analyses. And the Department of Labor, which is the main, for commercial plans, is the main regulator at the federal level, as well as Health and Human Services, who regulates marketplace plans. They have been actively requesting the analyses of health plans across the country and examining, whether or not health plans' treatment limitations are compliant with the Federal Parity Act. And it's great that they're doing this because honestly, they're finding a lot of problems. They released, the Department of Labor and Health and Human Services released a report, I believe it was in January of this year, which really the findings of this report were frankly pretty worrisome. And I think there's a lot of room for plans to improve. And they basically found that plans, analyses of their treatment limitations were not demonstrating compliance. And they actually, in many cases, found very clear instances of non-compliance. And just as one example of the things that they found, which we've actually known are parity violations for a long time, is like some health plans that they looked at, still had restrictions and actually exclusions on nutritionists for individuals who have eating disorders, where there were no such restrictions for nutritionists for if you had diabetes, which is a very clear parity violation. Yet, these types of exclusions, still existed. There were similar exclusions for things like applied behavioral analysis for, autism, and that violate the federal parity law, as well as they found that there were blanket pre-certification requirements for mental health and addiction benefits, where those requirements didn't exist for physical health. So this report, I think, was a major step forward because it really really gave some insight into plans practices. But this will be a conversation with plans going forward between regulators and health plans of making sure that they're compliant. And it's great that the federal agencies, are doing this. That doesn't alleviate the critical need, though, for state regulators, though, to be requesting these analyses of the plans that they regulate. And we have been working, as I mentioned, with states across the country, to put in place actually parity compliance, submission requirements, which basically health plans have to submit analyses that they've done on an annual basis. And I think roughly about 20 states have either through administrative action or through statutory, by enacting legislation, have put in place requirements that the insurers and in many cases Medicaid MCOs that they regulate have to submit to the state their parity compliance analyses on an annual basis, so the state can review them, for potential, to ensure that they're in fact compliant and identify any issues that need to be, worked out. Kansas is not one of the 20 states or 20 or so states that has yet, acted. That could be something good to put in place as an explicit requirement that the analyses that on the commercial plans already have to do that they have to provide them to the state. Again, Medicaid MCOs we think should be required to also provide these analyses to the state Medicaid agency. But it's it's really a trust but verify type thing where we need to, regulators need to be assuming that plans are trying to do the right thing, but verifying that in fact they are, so that enrollees can be assured to get the mental health and addiction benefits to which they're entitled. So I did want to pivot just really briefly to it, and this is very much related to parity, but is a little bit separate. I did want to discuss an important court case, although the issues go beyond this one court case, and it's relating to how plans make medical necessity determinations. So for those of you who, a little bit of background, a medical necessity determination is essentially the plan decides whether or not the patient needs the treatment that's being recommended by their clinician. And the plan can say either yes or no. If they say yes, then they will reimburse for those services. If they say no, then they won't reimburse for those services. And so this is a very critical question of how plans decide whether or not the recommended treatment is in fact going to be paid for. And we've long seen that there have been issues with how plans make these medical necessity determinations, and that the criteria that they use are oftentimes very stringent, and in many cases are not consistent with accepted clinical standards for mental health and addiction treatment. And so there was a very important federal court case that's been ongoing. It's called Witt versus United Behavioral Health, which is a court case that involves more than 50,000 class members across the country, including in Kansas has class members, I'm sure. That the court case was about one insurer, although we think this practice is common among other insurers as well. That United Healthcare used its own medical necessity criteria that inappropriately limited coverage for needed mental health and addiction treatment. So at the district court level, the judge actually found that this was the case, that United's criteria were not consistent with accepted clinical standards, and therefore resulted in inappropriate denials of mental health and addiction treatment. That decision, which really had been lauded in the behavioral health community across the country, including by the Kennedy Forum, has led several states, including Georgia and California and Oregon, to require that medical necessity determinations need to be made consistent with these accepted clinical standards, and with criteria like the American Society of Addiction Medicine criteria for substance use disorders, which is consistent with these standards. And so it's led to this being identified as a major issue. Now, the Witt case was appealed to the Ninth Circuit Court of Appeals, which is it takes appeals from the Western states. And there was a panel decision that actually reversed the lower court ruling, and the panel didn't say that United's criteria was consistent with accepted clinical standards. The panel essentially found that even if that's the case, it's okay for United to use criteria that's not consistent with accepted clinical standards. So that essentially they could use any criteria they wanted to limit care. So we're actually very worried about this decision. So there is a push to have the case be heard before the Ninth Circuit Federal Ninth Circuit Court of Appeals. That's ongoing, but the issue, regardless of how this court case is resolved, the issue still remains of whether plans should be allowed to use any criteria they wish to make these medical necessity determinations. Our contention is that they should not be allowed to do that. That medical necessity determinations should have to be consistent with accepted clinical standards, and that health insurance plans should not just be able to overrule doctors and other clinicians using any criteria that they wish, even if they're inconsistent with accepted clinical standards of care. And Georgia was the most recent state to put in place a requirement that in fact plans to do this. So it's an important case. It's definitely related to parity, even though it wasn't argued directly under the Federal Parity Act. But there are many. The Federal Parity Act is only one component of rules relating to behavioral health coverage. There are other very important rules like network adequacy standards. Kind of what the general appeal rights are. Those types of rules, both state and federally, are critically important to ensuring that patients can receive the care they need. So I will stop. I'll stop there, and we can begin. Hopefully having a conversation about these issues. I only scratched the surface of a lot of these issues, so I'm sure we can go more in depth, and happy to answer questions that people have.
Terrific. Thank you so much, David. And we do have a few questions in our Q&A. So if you haven't put your question in the Q&A, please do so. The Q&A, obviously, I'm ready for some lunch. First question for you, David, then. Would it be a parity violation for an insurer to impose requirements on behavioral health providers that are not imposed on other providers? For example, in Kansas, we have an insurer that is requiring behavioral health providers to meet attestation and other administrative requirements every quarter to qualify for enhanced payments, which may not be required for other providers.
Okay. Before I answer, because I'm often asked like these types of questions about specific barriers, I should say that what my kind of initial reaction will not necessarily be the definitive answer. But that certainly sounds problematic to me. In general, if there is a treatment limitation, and non-quantitative treatment limitation is any limitation that's non-quantitative in nature, and this is definitely a non-quantitative treatment limitation that limits the scope or duration of treatment. And that includes payment. So if it's a limitation placed on providers, that I would think that this could be problematic. I think it's definitely worth bringing. I don't know what type of plan this is, whether it says an insurer, so it sounds like a commercial plan. But I would take this. I usually urge providers and patients to get your ducks in a row. Have documentation, make sure you have evidence that you're not just coming to the department and saying this is an issue, and then when they ask for the details, you have nothing, you don't have it kind of ready. So make sure that you prepare, get details on exactly what the barrier is, and then I think it's worthwhile going to the department and having a conversation with them. We're going to the appropriate regulators, and I don't know whether this is a fully insured plan or a self-funded plan. But make sure you know what regulator it is, or what type of insurance it is, and then it's worthwhile having a conversation with them. And certainly to the degree you can bring in the provider association or in other providers, that will strengthen your case politically. If you're kind of one provider, if you get other providers who might be affected, together, to push the issue. But certainly, it sounds problematic. And generally speaking, the rule is that you cannot place a non-quantitative treatment limitation on behavioral health that is not placed on physical health within a classification of care. And a classification of care is, for example, in-network inpatient is a classification of care. And out-of-network inpatient is another classification of care. So the test always occurs within a classification of care. The analysis in each instance is bounded by that classification. And that's so that you're not comparing, say, prior authorization for prescription drugs in behavioral health to prior authorization to in-network inpatient on the physical health side, because it's basically designed to have an apples to apples comparison of bounding it within a specific classification of care.
It's helpful. Thank you, David. Next question. What might we ask our insurance commissioner in a meeting later this year about the work of the Parity Working Group at NAIC? Are there recommendations or best practices from the working group which Kansas should be considering for implementation?
So yes, I mean, even absent, we have in the past pushed for legislation to be enacted, which is always a bit of a passing legislation is always a process. Having worked on both state and federal legislation, and so there are many things that the department can do, without legislation, to really ensure enforcement. Broadly speaking, the insurance departments across the country have broad authority to ask questions and to collect information, regarding compliance with state and federal insurance laws. So, one of the things that the new federal law requires commercial health plans to do is to, for every non-quantitative treatment limitation in each classification of care, they have to conduct a detailed parity compliance analysis that basically shows that they meet the test under federal law, that how they design and are applying their treatment limitation to mental health or substance use disorder services is consistent with parity to how they do so for physical health. And importantly, the federal law, which actually amends the Federal Parity Act, so this is written into the Federal Parity Act requirements, explicitly says that state insurance departments can request those analysis from states under their, for plans that they oversee, and they must be provided those analyses. So essentially, the insurance department can request parity compliance analyses for any year, any or all NQTLs, non-quantitative treatment limitations, for for any or all plans, all insurers in the state of Kansas. So that provides a very powerful avenue for them to be, verifying, compliance with the Federal Parity Act. And so this is one of these types of, oversight is a lot of what's occurring at the MAPIA working group. We're talking about how to analyze, plan submissions. So if the Kansas, insurance department is not, hopefully it's requesting some of these analyses, because if it's not, I don't think there's any way for them to determine compliance on a moving forward basis. They can do it through market conduct exams after the fact. Although I always find market conduct exams kind of oftentimes too little too late for the patients who were denied coverage, several years ago, and who may be made whole after the fact in terms of, I say made whole financially, for care that they were paid for out of pocket. But if you didn't pay for the care out of pocket because you couldn't afford it and were denied coverage, you don't get anything, based on a market conduct examination that may occur years after the fact. So these kind of looking at the analyses is really critical to determining kind of ongoing compliance, rather than waiting for a market conduct exam, which in many states, I don't know offhand the requirements in Kansas. In many states, there are no requirements for how often the market conduct exam has to take place. And so I think in one state in Illinois, which I used to work in, there hadn't been a market conduct examination of the major insurer in 30 years. So, hopefully that's not the length of time. I think that was a major outlier. But they requesting the parity compliance analyses and analyzing them and using the MAPIA working group at NAIC as kind of a learning collaborative among state insurance departments, I think is really important. So asking questions about like, what are you doing? How are you requesting analyses? Like, how are you really pushing on that? I think can be really important. And also urging the insurance department to investigate any behavioral health complaint they get, even if the patient doesn't utter the magic word of parity because they don't know to do so, those should be investigated for potential parity issues, as well.
Okay, so we've got another question. Got several more, David. Patients are required to have appointments every 3 months to get new prescriptions for ADHD stimulants. Many have co-pays for each visit. Is this a parity concern or just something unfortunate?
So I think the question would be whether they have similar, they have the same requirement for, that exists on the physical health side. If the answer is no, I think that's very problematic. If the answer is yes, then there does come, like, the ultimate test will revolve around kind of how the plan has decided to place, a treatment limitation on behavioral health as compared to physical health, that it can't be more stringently done. And so in kind of layman's terms, the plan has to decide, they're going to impose it. They have a treatment limitation and they're going to decide when to impose it, when it's triggered on behavioral health. And then they also have to decide when it's triggered on physical health. And if they can't demonstrate that how they're making those decisions and how they're actually applying kind of that, how they're constructing it, if they can't show that they're doing that in a non-discriminatory manner, that would be potentially problematic, even if they did have similar limitations in some instances, on the behavioral, on the physical health side. And just kind of an example of this, there was one example of one large plan that I'm aware of in another state. Like they had, which is somewhat similar to this, is they said you have to get prior authorization after 7 visits for any outpatient mental health or addiction visit, which is actually a non-quantitative treatment limitation because it deals with prior authorization. And so, but it was applied to all mental health and addiction outpatient visits, which is basically, that's everything in that classification, essentially. And they had, and I think it was after 7 visits. And they said, well, we place a 7, after 7 visits, you have to get prior authorization for physical therapy on the physical health side. And they said, so therefore we're compliant. And we basically made the argument, no, you're not, that doesn't illustrate compliance. Physical therapy is a pretty small subset of outpatient physical health visits. And so you're saying that, you're talking maybe, 2% of outpatient visits on the physical health side, but you're talking nearly 100% on, the behavioral health side. So that doesn't even pass kind of the lab test of like, it doesn't pass any, real, cursory analysis of the Federal Parity Act. So a similar, analysis might be in play, here, depending on how frequently they're putting in place, if they have such a 30, I think you said 30 days, what was the trigger point?
Okay. So David, can you talk more about healthcare compliance and what that looks like for consumers?
Sure. I mean, that's kind of a broad question, but so healthcare compliance, like meaning both physical health and behavioral health all together, or is this? Do you want it to be? Do we know if the person wants just behavioral health? I will say that insurance departments and Medicaid agencies are responsible for overseeing the plans under their jurisdiction, and that's across all insurance laws. So we will often see that, like when you're talking about someone is denied mental health and addiction care or physical health care for that matter, their claim is denied by their insurer. The state will have requirements on kind of what the appeals process looks like, what steps you have to go through, how quickly the insurance company has to respond. And oftentimes, in our experience, those requirements are not necessarily followed. And without robust oversight by the regulator, those protections become meaningless if there's no one overseeing, those protections. So things like all those requirements relating to health insurance laws, they're critical that there be oversight and they be enforced. Otherwise, what's written into into the law, they're just words on paper and are not meaningful to patients. So certainly I think that's why oversight is critical in order to ensure compliance. So hopefully that gets at something at what the question was getting at. But no, the regulators really play a critically important role.
Thank you. So are the 20 states that have passed legislation passing bills that have the same language, i.e. do they have model bills, or are they developing their own language?
There's model language so the Kennedy Form has a model parity reporting bill that we've had for a number of years, although the core components of that were enacted into federal law. So and both the federal law and our model bill essentially takes the longstanding requirements in federal law of what compliance with for any non-quantitative treatment limitation, like what the test is that insurers have to meet, and it essentially breaks those down into the component parts. So a number of states now, and I think I believe Montana may have been the latest. In order to mandate appropriate parity reporting, essentially it's a very easy piece of legislation to write for the most part. You essentially say, on an annual basis, every insurer, subject to the insurance code in the state, must provide the department with the analyses, and you just cite the new requirement of federal law, of the little section of federal law, and that's basically it. In terms of mandating parity compliance reporting. So it's it's become pretty standard at this point, but I think it can be very powerful to making sure that that the insurance department is collecting the information. And there are also some other components of the model legislation that I'm happy to send along the link, link to that so that you can look at it. I should also mention that Texas, the Texas Department of Insurance has put in place really good data reporting requirements for insurers to basically help identify what might be red flags. That the idea is that we should be guided by data, and so if we're seeing very frequent denials for mental health and addiction services as compared to physical health services, that while that might not indicate that doesn't indicate a violation of the Parity Act per se, it may indicate it may signal a red flag that the insurance department may want to investigate, and dig a little deeper. And so Texas is utilizing very good spreadsheets, essentially, that insurers have to fill out that just highlight the comparative data between mental health coverage and physical health coverage, to guide them in their efforts to make sure that people are receiving the care to which they're entitled.
Terrific, thank you. And we'll look for that link.
Yeah.
So you've mentioned a number of reports. How can advocates get access to these reports, act on what's found in these reports, or are these things that only policymakers have access to, or, in our case, maybe the insurance commissioner can only access some of this information?
So the parity compliance analyses that are now required of commercial insurers, they're not required of Medicaid managed care across the country. Advocates can't collect them, but individual enrollees can request them and are entitled to be, they're entitled to receive them under federal law, and the federal departments have made very, very clear that that these analyses must be provided. Now, I will say that the enforcement of that requirement is pretty dreadful. That we've had, again, the enrollee in the health plan request an analysis from their health plan. The health plan doesn't provide it, and unless the insurance department takes action, and there has not, health plans have historically ignored the request. So it definitely is an area that needs to have aggressive enforcement where insurers are not meeting their clear responsibilities under federal law, where there needs to be action taken to ensure that they are meeting their meeting their obligations under federal law. But no, enrollees can request those analysis. And I did find the link quickly to this is the model state parity legislation that we have, that roughly about 20 states have enacted. I'm also going to drop in the chat. We have something called the Jim Ramstad model state legislation relating to generally accepted standards of care. Jim Ramstad was a Republican congressman from Minnesota who was co-author of the Federal Parity Act with Patrick Kennedy, and died. He passed away, about a year and a half, 2 years ago now. And so we named this model bill after him. So I'm also dropping that in the chat as well. And that has some of the provisions that have been enacted in other states relating to medical necessity determinations.
Thank you. So follow up to the last question about the reports. So if someone wanted to get the report, do they have to be, what I heard you say was you have to be an enrollee in that insurance plan to theoretically have access, even though the insurance company is not likely to give it to you. The follow-up is then, can you do a FOIA request, a Freedom of Information Act request to get that information?
Usually not. Usually that is not subject to FOIAs.
Okay.
And I think that the insurance departments can take enforcement actions against against the insurance plans that they regulate. And because of that, that usually limits kind of the discoverability of kind of the work, the insurance department's kind of work product relating to their enforcement actions. And so that is usually not available to the public. In our model state legislation, we do have, and a number of states have enacted this, there is a provision that essentially says that the insurer's parity compliance analysis should be made public. And so that is that's important. I think that's an important provision. Also, if you as an individual, if I ask my health insurance plan to give me my the parity compliance analysis for their non-quantitative treatment limitations, once I receive that, I'm under no restrictions in terms of what I can do with that. So if I wanted to create a website and put it on the website, I certainly could. And so that is that could be an avenue for advocates as individuals for their health plans to request analysis and then use it, analyze it yourself, or you could also share it with others without restriction.
So another question on what constitutes a parity violation. So if a provider is doing clinical reviews of behavioral health providers, but so say it's Blue Cross Blue Shield, and they're doing a clinical review, but other providers, okay, so sorry, let me just read the question because I was trying to summarize it and it's not working for me. Do the clinical reviews that Blue Cross and other carriers engage in for behavioral health providers represent a parity violation if they are not being implemented for other providers? So there are clinical reviews for behavioral health providers, but what if they're not implementing those for other providers? those clinical reviews. Is that a parity violation?
I think it'll depend a lot on the specifics. And so the more granular you can get with the types of reviews that are occurring, the better. The better your case will be. I think in general, plans can work to have the ability to get the information that they need to make medical necessity determinations. And so if that's kind of the information that they're requesting, they can't do it more stringently than they do for physical health, but you really, I think, need to get kind of specifics, and particularly if it's a kind of a how and what we might call an as applied treatment limitation, and kind of how they're doing it in practice. The more information you collect, the better in terms of being able to go to the department to try and get them to address some of the issues.
Great, thanks. We have one more question. So other than WIT, are there other parity challenges that are working their way through the courts?
There have been a big uptake in the past couple of years of parity cases within the federal courts, brought by individuals who've been denied care or denied coverage for treatment. And I think more and more cases we're seeing that they're being successful. I think court cases are critical. I don't think court cases are, hopefully there won't be a need for court cases. So, hopefully we will have regulators that have the primary oversight responsibility of health plans. You'll be doing a really good job so that we can be sure that individuals with mental health and substance use disorders are not experiencing discrimination. So there are a number of court cases. None of them I think are as big or as important as WIT, kind of in their scope. But each is important in its own right, and kind of for the individuals affected, and for potentially the precedents that they set. This one paragraph of federal law.
Great. Well, thank you so much, David. We really appreciate your time. I know we've passed the 1 o'clock hour, so we want to be respectful of your time. Thank you to everyone who attended and for all of your questions. It looks like we've got one more question. We can follow up with you offline, David, but thank you for all of the resources, and look for our next webinar series number 3, self-insured large employer health plans and their efforts, in late August. So we'll see you in August. Thank you, everyone.
Thank you.